If that in that case, if the patient is giving you a consent that this patient, I don't want him to get intubation or I don't want him to get CPR or something like that, and you feel like this is not enough for that patient, and if the patient was conscious, he wouldn't want it. So in that case, you need to do that. Okay. So in that case, you will assume, and in that case, you will try to save the patient. Uh, Assume that most people would want it to be safe in an emergency. Okay, so if the person is brought to emergency, it means you can assume that the person want to be saved. Any capable, and in that case, no, you will not be liable if you saved a person. Like later on said, oh, why did you save me? That in that case, we try to assume that this person might be not in their conscious mind or have like suicidal thoughts. So in that case, that's kind of different, like a psychiatry thing, right? But you need to assume if you save a patient and the patient doesn't has an shown a consent that he does not want to be saved, you need to save that patient. That's a psychiatry thing. But if a patient has done DNR or stuff like that, where he does not want to do a resuscitation or like a life-saving procedure, in that cases, what you can do is you need to follow the consent of the patient or that documents because it's now been done and it's done in the patient's full conscious mind. Okay, so in that case, you don't need to assume that this patient needs to and is doing suicide or DNR or something like that. Okay, or he's a psychiatric patient. Okay, any capable and informed patient can refuse treatment or part of the treatment. Okay, even if it's a life-saving treatment like appendicitis. There are people who don't want to do appendectomy. So even for acute abdominal obstruction, people don't want to do the surgery right away. They be like, we will see if I'm able to pass the flatus and stuff. So although it's a very life-threatening, it can cause a lot of problem for them later on. But if he's saying, no, I don't want it, so you're not going to do it. Okay. Be aware of who the legal substitute decision maker, like say STM, is and contact them early if possible. Then expectations to the emergency rule is basically a competent patient has previously refused the same or similar treatment, and then there is no evidence to suggest the patient wishes have changed. So in that cases, treatment cannot be initiated. So let's suppose if a patient came to the emergency and you have done something for that patient, uh, and in that previous treatment, when he got conscious, he said, oh, I don't want it. In the next thing, you are going to do it again for that person. In that, why? Because it was not a legal written document for that person. Okay. I'm just giving a scenario. But if a person came, like, as in, let's suppose, appendicitis, right? If he was conscious, he was okay, and we suggested him to do appendectomy. So he said no. Now he came with the appendial perforation where the appendix perforated. He refused that treatment at that time. So in this case, we are not going to do the appendectomy. We might start with IV antibiotics and whatever possible ways we can do for that patient, but we are not going to do appendectomy right away. Although it needs to be done, different things. But in this case, this says there is no evidence to change the patient wishes have changed. Like it happened 2-3 days ago, and now 2-3 days later on he came back. So it means the wishes hasn't been changed. Although you can contact his family physician, he might have talked to the family physician. He tried to maybe thought of those ones. So those cases are different. You can always, they said you can try to contact them. But at this point, you are not going to just directly start with the surgery. Okay. An evidence directive is available. Do not resuscitate order. So in that case, you're not going to do. Refuse or help in a suicidal situation is not an exception. Care must be given. As I said, this is a psychiatric case. If in doubt, initiate treatment. As I said, if you initiate the treatment, even in this case, the appendial perforation, you start with something or surgery or something, no one is going to give you liability for that. Like, oh, why did you do that and stuff? He told this is be like it was the patient's. We were trying to save that patient. We did not know what he wanted, so we just want to save his life. So you can always do that one. You will not be, liable for anything. Can be withdrawal if necessary at a later time. Let's suppose in the middle of the surgery, we got contact with the family physician or someone, and they said, oh, we don't want to do appendectomy. In that case, we're going to stop the surgery right away. Okay. If wishes are clarified by the family, consent to the treatment is basically for the children. Treat immediate if the patient is at imminent risk. Parents and guardians have the right to make treatment decisions. Very, very important. The children, okay? So let's start with a scenario. So there is a scenario, there is a child, their parents got divorced. So the father came to the treatment, you as a, let's suppose go with a emergency medicine, okay? So you started antibiotics for some sort of infection. And mother called and be like, why did you start the antibiotics to my child? And we don't want it, right? So in that case, what are you gonna do? In that case, like now the father was willing to start it, but the son or the mother was not willing to start for the treatment of that son, right? So in that case, you are as a family physician. Now it's gonna be a different approach for a family medicine, but it's going to be a different approach for emergency medicine. In emergency medicine, we are going to check if how much the severity of the infection, if it's going to be life threatening, how much it's going to be affecting the child, and how much the necessity of taking the antibiotics for the child is. Okay. But in case of family medicine, it's kind of a bit different. We are going to talk, we are going to bring the both family together, make them understand why the treatment and stuff like that. We have time for that. So in that cases, we can do a lot of talking. But in this case, in the emergency, we have to make the decision by looking at whatever it is. Okay. So approach is different, although the case is similar. Okay. So have that right to make the decision up to age of 16. So parents and guardians are going to make the decision. If the parents refuse treatment that is considered life threatening or will potentially alter the child's quality of life, CAS must be contacted. So in that case, you can contact the CAS as well. Okay. I was especially like I recently saw a case where the mother wanted to start an ADHD treatment for the child, but dad does not want to start it. So in that case, we do a lot of talking with the dad, try to explain, bring the mom and dad together, explaining how important the ADHD treatment is, what is the side effects of ADHD, what could happen, and all that. So bringing them together. Although if they were not willing to listen, that's a different thing, right? So like we can do always the talking, and in family medicine we can stop the treatment for temporary basis, but in emergency we cannot stop it based on how much the severity of infection and how much the things is going on. Okay. So then other issues of consent is required for HIV testing or administration of the blood products. However, if delayed constitute or substitute consent for the blood transfusion puts patient at risk, transfusion can be given. Okay. So let's suppose in Jehovah's Witness and stuff, we are not 100% sure he's Jehovah's Witness and all that. You can start the treatment or transfusion, and later on you find out, then you can stop the treatment. Law may vary depending on province or state. So gunshot wounds suspected. So this is where you have to report. Especially, I think gunshot wounds, suspected child abuse, communicable medical unsuitability to drive and risk to substantial harms, or deporting someone. These are the things that I think that you have to, or STI treatment. I think you have to report these ones, regardless of that. I think in every province. I'm not sure in the other province, but yeah, in this province, you should do that one. I mean, in major provinces like Ontario, Manitoba, Saskatchewan, they do this one. I'm not sure about Quebec. Okay. Then Jehovah's Witness. So I think when they're asking in MCQs or in exam, they try to ask the general point of view. They don't go for like province by province. Okay. So in gunshot wound, child abuse, communicable, medical unsuitability to drive, and then substantial harms, in those cases, we do report them. Jehovah's Witness capable, this is important, you have to highlight and remember these ones. Jehovah's Witness capable adults have the rights to refuse the medical treatment, may refuse whole blood, packed RBCs, platelets, plasma. So you need to know which one are they like actually refusing. Should be questioned directly about the use of albumin. So even if you are giving albumins, immunoglobulins, hemophilic preparation, you have to ask them fully like this product, are you willing to use it or not? Okay. Should be questioned directly about these ones. Do not allow autologous transfusion unless there is an uninterrupted extracorporeal circulation. So like it's like the same blood using again. Usually ask for the highest possible quality of the care without the use of above intervention like crystalloid, attempts for the bloodless surgery. Patients will generally sign hospital forms releasing medical staff from liability. Like usually when you enter, they do get the signs and everything. So most legal cases involve the children of Jehovah's Witness. If life-saving treatment is refused, contact the CAS. Okay. So there's this much, and you can read ethics for the emergency medicine from different books too. And if you have any questions, you can always ask me. Okay. there is more, okay? This is not enough. Coming to traumatology, traumatology is very, very important. We do see a lot of cases on daily basis. So even in the exam point of view, they'd like to check it a lot, okay? Starting from this one, leading cause of the death in the patient is less than 45 year. Then trimodal distribution of the deaths, minutes, early days, and weeks. So minutes, early days, and weeks, the deaths usually at the scene from the legal injuries. Early, like death within 4 to 6 hours, like golden hour, decreased mortality with the trauma care. Days and weeks, death from the multiple organ dysfunction, sepsis, and VTE. Then injuries fall into two categories, blunt and penetrating. There is minor and then major too. Okay, so they're talking about the categories. The blunt one is basically motor vehicle collision, pedestrian, automobile, motorcycle, and they like to ask you which one are which ones. Okay, so which one are blunt ones, which is most common, and which one is penetrating wounds. So you need to know. Okay. Then coming to the penetrating gunshot wound, stabbing wound, and emplacement. Okay, so in those cases, we don't remove the object. Always completely expose and count the number of wounds, especially when there is abuse. Okay, it does not mean that just only in abuse. I said especially in abuse. Okay. Consideration for the traumatic injury, important to know the mechanism of injury to anticipate the traumatic injuries. So starting from history, okay, or getting to know from whoever is bringing, like even the paramedics, you have to ask them what happened, okay. Always look for an underlying injury like alcohol, medication, substance, asking about the patient was in under alcohol, or patient was taking any medicine, seizures, suicidal attempt, or medical problem, or was he taking any medical history. So, talking about all the medications. Always inquire about homicidal incidents, loss of consciousness, head injury. Sorry, this is head injury, not all. Head injury, loss of consciousness, amnesia, vomiting, headache, and seizure activity. Cardiac box, what is cardiac box? Sternal notch, nipple. So Z5 process, that's called the cardiac box. Mechanism of consideration of traumatic injuries. So special consideration, associated injuries. What could happen? What could happen? Especially in this one, the motor vehicle, pedestrian automobile impact, and falls. This table is very important. Although it looks very useless, but it's very important. Okay. So vehicle involved is basically depending on the weight, size, speed, damage, location of the patient in the vehicle, where he was sitting in front, in the back, use and the type of seat belt, ejection of the patient from vehicle, entrapment of the patient under vehicle, airbag deployment, helmet use in the motor vehicle collision. So what kind of injuries could happen? Head-on collision, like on the face, head, and thoracic, and up to upper extremities, like above to the umbilicus. Okay, that comes the head-on collision. Then lateral on the or T-bone collision. That's head, C-spine, thoracic, abdominal, pelvic, and lower extremities. So lower to those ones. Then head rear end collisions, starting like coming from the side, hyperextension of the C-spine, like whiplash injury. It's a very common whiplash injury, okay? And you need to know how does the whiplash injury presents. I think it's not mentioned in the Toronto note, so see it from Google. And what kind of symptoms is in the whiplash? Roll over all of the above may be associated injuries. Pedestrian automobile impact, high mobility and mortality, like it was the pedestrian is like on the walking and then the car was coming. Okay, vehicle is an important factor, site of impact on the car, and then adult tend to be struck in the lower legs or impacted against the car or thrown out or had a head injury. Falls, very, very important. Falls like story. So one story is 12 feet. So they can tell you 12 feet, 3.6 meter, or one story. So you need to know they all are same. Distance of the fall is 50% mortality at 4 story. Then coming to the 7 story, it's like 95%. So landing position depending on vertical or the horizontal. So vertical is basically lower extremities, like usually the fracture is on the lower extremities. Coming to the pelvis and spine fractures, okay? So patient later on does not present right away with the lower extremities, but later on can present with a pelvic fracture or spine fractures in those cases. Horizontal, if it's falling on the front wise or in the back wise. Then high risk injuries. High risk injuries is basically motor vehicle at high speed. This is important. They do like to ask what are the high risk injuries. Motorcycle collision, vehicle and pedestrian crashes, and fall from story. This fall from story is actually, I think there is an MCQs of that one too, an MCC practice test too. Vehicle versus pedestrian crash in adults, look for the triad of the injuries. Weddell's triad, tibia, fibula, or the femur fracture, truncal injury, and the craniofacial injury. Coming to the head injuries, we're going to start with the CT scan, pelvic examination, non-contrast CT scan. So we can see what is going on, okay? Skull fracture, the wall fracture is linear, non-depressed, most common. And I would suggest to go to the neurosurgery and do a little bit of reading from there too, okay? Linear, most non-depressed, and pictures, very important. Most common typically occur over temporal bone, and in the cases of the middle meningeal artery, commonest cause of the epidural hematoma. They do like to ask you which artery is the most common cause, okay? Then that's a linear, this one is depressed. Depressed is basically open, whereas there's a laceration or torn or skull fracture disrupting versus closed one. And how you're going to approach the skull fracture in children's. Although it's a case of pediatrician, but you as an emergency physician is handling the first line, like, when it just came, you have to do the first initial treatment. So basal skull fracture, basal skull fracture associated with the Battle sign, raccoon sign, hemotympan, CSF right arteria. So they like to ask these signs, okay? So you can see from the sign, Battle sign, hemotympanum, raccoon, and CSF. Now we are reading it. I would like you to do all the sidebars of Toronto notes, each and every single one. There's a lot of questions that comes from the sidebars, okay? Facial fractures, neuronal injury, beware of the open fractures and sinus fractures. Then where facial fractures may pose risk to the airway thrombosis. Then comes to the scalp laceration, can be source of the lacerating bleeding. Achieve hemostasis, inspect and palpate for the skull bone, checking for the CT scan. Neuronal injury. Okay, so you as an emergency physician, if a patient comes to you as a scalp laceration, he just have a laceration on the scalp and there is bleeding. So you as a family physician, not family physician, sorry, emergency physician, you are going to start with a history, talking and all that. Then, stopping the bleeding, do the bandage, okay? Giving the first line treatment if needed, like maybe a painkiller, and that's it. You don't need to ask the patient to come back or something like that. If that's a different case, if he's having headache or sears or trauma or vomiting, nausea where the ICP is raised, that's an emergency case. But asking them to follow up with a family physician if he needs to do the change of dressing, if he needs to reassess for the stitching, removal of stitching, that's now a family medicine practice. Only stabilizing a patient, giving first line treatment. Don't go for more than that, like giving antibiotics and stuff like that, okay? Then neuronal injury, even when we do wound cleaning or washing or cutting of the wound, or how do I say it? Like how diabetic wound presents, right? So in that case, it's just cleaning the wound. We don't prescribe antibiotics as an emergency physician. The prescription of antibiotics for the diabetic wound or the infected wound is supposed to be done by a family physician. So you just do the first aid, like removing all the pus, cleaning, doing the bandage, everything. Maybe needed a painkiller, then give just painkiller for a few days, like maybe 7 days or 5 days, and then discharge the patient and send the patient to the emergency. So don't be extra person to start giving antibiotics as an emergency physician. The antibiotics and stuff is going to start by the family physician, okay? Then as it says, achieve hemostasis, inspect and palpate for the skull bone fractures. CT had rule out the skull, and then you stabilize the patient, discharge, and tell the dangerous signs and come back if it's more than that. Then neuronal injury, diffuse, mild TBI, concussion. How does the concussion look like? It's very important. See the pictures from Google, okay? GCS 13 to 15 patients are awake, may be confused, but able to communicate and follow commands. Transient alteration in the mental status that may involve the loss of consciousness. Hallmark of concussion is consciousness, amnesia, which may occur immediately after the trauma or minutes later. So loss of consciousness must be less than 30 minutes and post-traumatic amnesia must be less than 24 hours. Then diffuse axonal injury is basically leading towards coma, 6 to 24 hours, lasting deficit, moderate, comma more than 24. Swear is basically more than 24 with signs of brainstem dysfunction. Now, what is important here? Although it's important knowing for how mild, moderate, and severe it is. Now, when are you get back to the work? So it's not you as a emergency medicine are going to deal with. You as a family medicine are going to deal with that one. Okay. So we will read it when we will do the emergency family medicine. So read this one, how much you are going to attempt with that case. Okay. So knowing about when you are discharging the patient, letting them know what are the raised signs of ICP, what are the later on changes that can happen with the hand injury, and in which cases you need to come back. Okay. Don't try to start something which is not needed as an emergency medicine. Only like I'm saying that if you are asked a question in MCQ1 like an exam, uh, like as an emergency physician. Okay. So you need to know the limits as an emergency physician and as a family physician. Focal injuries is contusions, intracranial hemorrhage, epidural, subdural, and intracerebral. So it's important how does they look like. The picture. Assessment of the brain injuries, pre-hospital status and the mechanism of injury. Pre-hospital physical examination is the C-spine injury until rule out. Vital signs, severity of the injuries determined by level of consciousness, pupils, lateralizing sign. Warning signs of the severe head injury is GCS, deteriorating GCS. Unequal pupils, lateralizing sign. If pupils, both eyes are equally reactive or equally non-reactive, then you can think of poisoning as one of the thing too. Okay, don't forget about poisoning. But if it's lateralizing like only on one side, then that's a different story. Or unequal pupils, that's a different story. Okay, that could be stroke and all that. Then we're going to start with the investigation: CBC, electrolytes, INR, PTT, glucose, toxicology screen, CT head, and C-spine imaging. Now, let's suppose in MCQs, they ask you to choose one. So on the basis of what the signs are there, like unequal or equal pupils that you can find out, you need to do toxicology because it could be poisoning. And if it's not, then you can go for CT head. That's why I said don't need to assume things. You need to see, and when you are doing it, any test, you need to know why you are doing it. Okay, just reading CBC is not enough. You need to know why are you doing CBC. Maybe I'm checking for any infection, any like meningitis, right? Here the checking is not hemoglobin. Here the checking is maybe meningitis or any sort of infection. Electrolyte checking for hyperkalemia, hyponatremia that can affect your CNS alteration. INRPTT, why? Because there could be bleeding or stroke going on, or maybe the patient is on warfarin or heparin. Glucose, checking for hypoglycemic episodes, toxicology, checking for poisoning. So that's why it's important. Okay. I'm not going into very, very details of this, but if you feel like you need to know why we're going to do CT scan, just ask me. Or then comes to the management goal in the emergency: reduce the secondary injury by avoiding hypoxia, ischemia, and decrease CPP, central perfusion pressure, and then seizures, cerebral perfusion pressure. Sorry. General ABCs. We're going to start with that. Ensure the oxygen delivery, maintain the BP, then treat the other injuries. Like if there is any other injuries, hand injuries or anything. Early neurosurgical consultation for the acute and subsequent patient management after imaging. Seizures, very, very important. It's could be presented with that. So we're going to start with benzodiazepine, phenytoin, phenobarbital. So just to let you know that benzodiazepines, phenytoin, and phenobarbital, these are the things that family medicine cannot prescribe. Okay, so these are the things only needed. They don't prescribe it on the daily basis. But benzodiazepine, phenytoin, phenobarbital can be prescribed by emergency medicine because that is a different practice. Okay. Treat suspect raised ICP, intubate, calm, paralyze if agitated, hyperventilated, elevate head of bed to 20 degree, adequate BP, and maintain the mannitol. So how you are going to start, it's very, very important. Go for non-invasive treatment first, then go for invasive treatment. Like starting with like if there is a breathing issue, then you can start with intubation first. But if it's not, then you can always calm the patient, like hyperventilate, elevate the head. Those are non-invasive. So you can start with those ones and then you can go for invasive ones like intubation. But as I said, intubation can be, checking on the breathing rate. Then the mannitol and stuff. It's basically invasive ones where you make IV, okay? Disposition neurosurgical ICU admission for severe head injury. As I said, we are done with first aid. We did everything to stabilize the patient, means the bringing the vitals one time normal. Now It's the neurosurgeon who's going to deal with everything. In a hemodynamic, and then we don't need to worry about rest of the thing. In a hemodynamically unstable patient with other injuries, prioritize most life-threatening injury. This is called triaging. So you need to know how you're going to triage, like which could be life-threatening. Let's suppose a patient has 10 injuries. You need to assess which injury you need to treat right away. This could be asked in MCQs as well, giving you different scenarios. Okay. And maintain cerebral perfusion, like head injury, spine injury, shoulder injury, pelvic injury, and then head injury was like a scalp laceration. Patient is conscious. It means head is okay. We don't need to worry about that. Spine injury, it says there is spine injury, but patient is moving okay. His hands is working. Neurological assessment is done. Everything is fine. Now, when it comes to pelvic, he's unable to move his pelvis or he's having too much pain in the pelvic area and you can see a hematoma on the pelvic area. Now, although the head injury is very dangerous, spine injury is very dangerous, but we are going to focus on the pelvic one. Why? Because they give you clearly what is going on here. Okay. So you need to triage the patient and you need to see which injury is more life-threatening and I have to focus on that one. Don't just stuck with the, like, this like head injury. For minor head injuries, no requiring admission. So provide 24-hour head injury protocol. So this is what I was talking about that you have to tell the patient. Regular assessment of the patient for signs of consciousness, confusion, amnesia to competent caregiver, follow up with the conscious or sport clinic as even seemingly minor head injury may cause the lasting deficit. Now comes to the CT head rule. So when are you going to the CT scan? CT head rule is only required for the patient with the minor head injuries with one of the following. So minor head injuries mean like he got hit, but there was no obvious thing going on. High risk means like his GCS deteriorated, although he hit a little bit, maybe on the side of the footpath. But what happened is his GCS is deranged, less than 15 at 2 hours after injury, suspected open or depressed fracture where you feel like he's confused, he's not conscious enough or agitated, any signs of basal cell trauma. So it means this is a high risk. Okay. Although injury was minor. So don't mix up these things. Injury is minor, but risk is high. Then vomiting is more than 2 absolutely means the ICP is raised. Age is more than 65 years. Okay. So, I want you to know why are you checking vomiting? So if you don't know why you're checking vomiting, if it's ICP raised, then you are like just things doing without knowing what you are doing. Okay. And then exams, they want you to know what you are doing. Then medium risk for the brain injury on CT scan, amnesia before impact of more than 30 minutes. Dangerous mechanism is basically pedestrian struck by motor vehicle collision. So this is basically dangerous. So this is basically medium risk. Minor is basically defined as the witness loss of consciousness and then regained the consciousness and now he's doing totally fine, 13 to 15, very non-agitated and, responding to everything. Okay. Then comes to the mild traumatic brain injury. Mild traumatic brain injury is basically the it might need hospitalization and ED visits each year. So they say, okay, this one. Now coming to the highest risk is basically in the children, 0 to 4 years, adolescents, 15 to 19, and elderly more than 65 years. The age is important too, okay? Clinical features is somatic like headache, sleep disturbance, nausea, vomiting, blurred vision, cognitive functions. So based on what functions are these ones? Attention, reduced speed, drowsiness, and amnesia. They can ask in MCQs. The patient is having reduced processing speed, or maybe they ask you which cognitive dysfunction you would like to see in this patient, which has traumatic mild injury. So you need to see which are the traumatic dysfunctions. Or what are you assessing? Emotional and behavior, impulsivity, irritability, and depression. So depression is one of the very important things. So when patient presents with depression, you always have to ask about the brain injury. Severe concussion may participate the seizures, bradycardia, hypotension, sluggish pupils. So depression does not present in emergency until he's doing suicide or something. Depression usually presents in family medicine. Etiology is basically falls, motor vehicle collision, struck by an object, assaults, and then sports. Extent for the retrograde amnesia correlates with the severity of injury. Investigation, examination is the first hand thing. Then concussion recognition tool. Then imaging, CT as per head, that's what we saw when are we going to do CT scan, or MRI worsening cases. and then CT scan is normal. Close observation follow for the patient. So we are going to check and risk of the intracranial complications, give appropriate discharge instructions to provide and family, tell them, in which cases they need to come back. Hospitalization and the normal CT scan or with abnormal CT scan, pharmacological management of the pain, depression, headache. As I said, we do give painkillers as an emergency physician, but no treatment more than that. Then follow return to play, basically return to learn guidelines. That's basically done by family physician. For minor pediatric head injury with GCS more than 13 and injury within the last 24 hours, use the Canadian assessment of traumatology, those ones. So what are those ones? These are the thing. CT head required if any of the following is there: GCS, suspected open, worsening of headache, irritability, signs of the basal skull fracture, hematoma, dangerous signs of mechanism of injury. Then prognosis is basically most recover with a minimal treatment. Like athletes and the people who have concussion, they are high risk of having headache, depression. They need to follow up with a family physician. And repeat TBI can cause cerebral edema. Very important. Just underline this line. Highlight this line. Spine and the spinal cord trauma. Then coming to assume cord injury with a significant falls, deceleration injuries, blunt trauma. Why I keep on focusing and like these lines? Because they like to ask you like what are the injuries or which injuries can cause this kind of traumas. Okay, so deceleration trauma, blunt trauma to head, neck, and back can cause spinal cord trauma. Okay. Then spinal immobilization must be maintained. As I said, cervical collar, cervical board during patient transport only. These are two very important words. Which one? Cervical collar, spinal board during the patient transport only. Okay, so these are one because even with the motor vehicle collision, we usually do this one. Vertebral injuries may be present without the cervical spinal cord injury. So normal neurological examination. Sometimes vertebral injuries are not there, but there is spinal cord injury. So it can come in different ways. Although it's written here, but I saw a patient recently like that. Cord may be injured despite the normal C-spine X-ray. Okay, cord may be injured, as I said. Injuries can conclude the complete and incomplete transaction, cord edema, and then spinal shock. History. Are you going to ask the sample, neck pain, paralysis, paresthesia, asking about all the neurological signs? Every patient with one of the following signs and symptoms should be placed in C-spine collar. So these are the patients we are going to the C-spine collar. It's very, very, very important. Which one? Midline tenderness, neurological symptoms, significant distracting injuries, head injury, intoxication, dangerous mechanism, or history of altered level of consciousness. I think it covers everything. So then comes to the physical examination, ABCs, then abdominal, ecchymosis and tenderness. Sorry, neurological complete examination, spine, we're going to check for the neutral position, palpate C-spine, log roll to check for both front and the back, the palpate T-spine, L-spine, rectal, assess the rectal tone, DRE, okay? So when palpating, assess for the tenderness, muscle spasm, bony tenderness, step off, and then spinous process malalignment. Then comes the extremities, check for the capillary refill, suspect the thoracolumbar injury with the calcaneal fractures. Corda-equina syndrome, important, very important. Of the investigation, CT is the best injury in modality to assess the C-spine, okay? But if unavailable, then you can always go for X-rays. Corda-equina can occur with a spinal cord injury below T10. And what kind of symptoms are there? Look for incontinence, high pain, quadricep weakness, sacral sensation, rectal tone, and reflexes. This is also important in terms of neck osteoarthritis. Then blood work. What blood work are you going to do is basically CBC, electrolytes, same thing, creatinine, because people who have acute kidney injuries going on, they can also have the same. Then glucose, coagulation profile, cross type and toxicology screen, then go for CT scan, CT of the spine, C-spine and conscious patient, neurological symptoms and deformities that are palpable when the patient is log rolled, and back pain, bilateral calcaneal fractures, MRI if appropriate, if needed for soft tissues injury. And sometimes people come with like, oh, I want to do MRI. So we don't do MRI right away. We go for X-ray first, okay? Can clear the C-spine if oriented to person, place, and event. No evidence of intoxication, midline tenderness, as they said, which are those ones. Non-focal neurological deficits, no painful distracting injuries. Okay, so in those cases, we don't need to put the cervical collar. Management of the cord injury, how you're going to start basically immobilization, putting the cervical collar. Then evaluate the ABCs, treat the neurological shock, insert NG for decompression of the paralytic ileus and Foley's catheter for the urethra if there is no concern of urethra. Complete the imaging of spine and spine, consult the spine surface. Continually reassess the high cord injuries as edema can travel up the cord. If cervical cord lesions, watch for the respiratory insufficiency. Very, very important. That's why I said vitals. We'll keep checking the vitals. Low cervical transaction, but in your case, they can ask you in MCQs, be like, if cervical cord lesion, what are you going to check? So watch for the respiratory, because in cervical, like the one that's close to neck, not the thoracic, not the lumbar, but they're mentioning the cervical one. What are you going to check? The respiratory one. And in the high cord injuries, what are you going to check? Edema. So these are the questions that they can ask. Low cervical transaction includes the abdominal breathing, like the phrenic nerve, because there are nerves coming from there, so nerves are the problem. High cervical cord may require the intubation and the ventilation. If the patient is in shock, treat with warm blanket, Trendle and Burke position, volume infusion, and then consider the vasopressors. As I said, start with the non-invasive, then go for invasive. Non-invasive like warm blanket, Trendle and Burke, volume, then volume infusion, those ones. Approach to C-spine imaging. CT of the spine is the screening modality of the choice. CT spine, CT can detect up to 97 to 100%. Capability of the radiology, CT scan allows for more rapid clearance of the C spine. So MRI is the preferred technique for the soft tissues like spinal cord injury. Let's suppose you did X-ray, you find out there's nothing, but patient is having, paresthesia and numbness and stuff like that. Then in that case, you can go for MRI. CT or C spine is the preferred modality if only C spine X-rays are available. Then on the sidebar, this is very, very important. As we already know the CT head rule. Now coming to this one. For alert patient is equals to 15, stable or trauma patient where the C spine is a concern. Any high risk factor that mandates radiography, ages like 85 year or dangerous mechanism or paresthesia is there. So if there is no, then we go into this side. If there is yes, then go for radiograph right away. If no, then what are we going to check? In that case, we are going to check the risk factors or the safe assessment of the range of motion, checking for the motor vehicle collision, sitting position in emergency department, like if he's falling on one side, drowsy or sitting erect or conscious, right? Ambulatory at any time, like need oxygen or something like that, delayed for immediate onset of the neck pain. So there is a neck pain going on, absence of the midline C spine injury. So in those cases, where like first we go for the age factor, dangerous mechanism, paresthesia. If there isn't any of that, then we will move on to these things. If there isn't any of that, then we like nothing, like there is absence and all that. If there is nothing, then we just to like rotate the neck and then all that. If they is able to rotate the neck, then you don't need to do anything. If he's unable to do, then you go for radiograph. Radiograph means doing CT scan. So it's very important in MCQs. What are the options they have given? If they have given 5 years, then you don't need to anything. Then just go for radiograph right away. If they have given there is no 85 years, there's no dangerous mechanism, no paresthesia, then in those cases you will look for these things. If any of these are there, then you will go for radiograph. So these questions come very tricky. What are the dangerous mechanism? Fall from a meter distance, motor vehicle collision, motorized or bicycle collision. Then motor vehicle collisions are which one? Hit by the bus or rollover or a hit high speed, pushed onto oncoming traffic. So these are all the motor vehicle collisions. So it's very, very important to read it in every single possible way. Try to make scenarios in your head and solve it. It can come this way, it can come this way. It can make you to memorize this for long period of time. Okay. And you can always keep the, small, things keep in your head as in shortcuts. Okay. That's how I try to memorize. So you can always see that too. Okay. Then indications for the lateral view view the ABCS, adequacy, the bones, cartilage, soft tissues. The adequacy and the alignments follow the anterior and the posterior contour lines. So we are going to check for everything, starting